Good morning all. Today we'll be seeing about an interesting topic, that is diuretics. So before we move on to the actual topic, we should know why we want to learn about diuretics. Because these drugs, they are useful in treatment of various edemas. Like they are useful in treatment of acute pulmonary edema, in heart failures, in case of cerebral edema. So we should know about these drugs in detail regarding their mechanism and side effects. And you should know what are the commonly used diuretics. There are so many diuretics, and loop diuretics, osmotic diuretics, thiazide diuretics, they are the most commonly used. And what are the drugs that are available in government hospitals? As I said, loop diuretics. So among this group, you have furosemide. We can see in the vial it will be written as Lasix, right? So furosemide is commonly available in government hospitals. We can see it in medicine ward, in IMCUs and all, right? And mannitol is one another osmotic diuretic. It's useful in treatment of cerebral edema, and we can also see thiazides like hydrochlorothiazide. All these are routinely used in government hospitals. So let's see where these diuretics act. You all know the various parts of nephron, like proximal convoluted tubule, loop of Henle. You will be having the descending limb and the thick ascending limb of loop of Henle, distal convoluted tubule, and collecting ducts. So these various groups of diuretics, they act on various sites in the nephron, like your carbonic anhydrase inhibitors, they act on the proximal convoluted tubule, right? So carbonic anhydrase inhibitors, they act on the proximal convoluted tubule. And loop diuretics, as the name itself implies, they act on the loop of Henle. Okay, they act on the thick ascending limb of loop of Henle. And comes your diuretics, that is thiazide diuretic, they act on the distal convoluted tubule. And potassium sparing diuretic, they act on the collecting duct. Okay, are you clear? So proximal convoluted tubule, the drug acting on it is carbonic anhydrase inhibitors, and loop of Henle, thick ascending loop diuretics will act on that. And on the distal convoluted tubule, thiazide diuretics will be acting on that. And in the collecting duct, your potassium sparing diuretics act. Okay, so these are the various sites of action of diuretics. So depending upon their efficacy, these diuretics can be classified as high ceiling, that is high efficacy diuretics, medium efficacy diuretics, and low efficacy diuretics. So your loop diuretics, they come under the high ceiling diuretics. Okay. So first, let's move on with let's move on with carbonic anhydrase inhibitors group. Okay, carbonic anhydrase inhibitors. Okay, so these drugs, they act on proximal convoluted tubule. So in the first slide, I have given a teacup or a coffee cup, an image, right? Because any type of drinks almost mildly stimulate some diuresis, right? So we can remember by drawing a teacup or a coffee cup like thing to know the mechanism easily, right? So assume this is your proximal convoluted tubule. This is the cell and this is your basolateral membrane. Okay, basolateral membrane this side, and this side you will be having the luminal membrane. Okay, luminal membrane. So whatever is lost in urine will be lost here, and whatever is reabsorbed will be crossing your basolateral membrane. And almost in all parts of the nephron we have this pump, that is sodium potassium ATPase pump. Okay, sodium potassium ATPase pump, and this pump is present on the basolateral membrane side. Okay, so which will pump sodium inside, so sodium will be reabsorbed. Okay, and in proximal convoluted tubule we have one another antipode. So this is your sodium hydrogenion antipode. Okay, so sodium hydrogenion antipode. So normally what happens, so this is present in the luminal membrane. So the sodium hydrogenion antipode is present in the luminal membrane, which will cause reabsorption of sodium by crossing this luminal membrane, and hydrogenion will be exchanged and lost in urine for the exchange of sodium. So normally bicarbonate ions will not be as such absorbed, it cannot cross this luminal membrane. So these bicarbonate ions, they combine with the H plus ions and form carbonic acid. This carbonic acid is split by the enzyme carbonic anhydrase to form H2O and CO2, which can easily enter the cell. Okay, so which can easily cross the luminal membrane and enter the cell. This again, in presence of carbonic anhydrase, they form carbonic acid, which again will split into H plus and HCO3. This HCO3 will be reabsorbed. It will cross this basolateral membrane and it will be reabsorbed. So this is the thing which is normally happening in proximal convoluted tubule, right? Okay, so there will be Na plus K plus ATPase pump in the basolateral membrane, which will promote the reabsorption of sodium, and the luminal membrane will have this Na plus H plus antipode, which will make the sodium to enter the cell and hydrogen ions to leave the cell. So this bicarbonate ions, they combine with this H plus to form carbonic acid, which in the presence of carbonic anhydrase enzyme will get split into H2O and CO2, which will easily cross the luminal membrane, which again they form carbonic acid inside the cell, which again splits into H plus. So this H plus is generated with the help of this carbonic anhydrase enzyme, and HCO3, which again crosses this basolateral membrane and it gets reabsorbed. So what happens when you give carbonic anhydrase inhibitor? How they produce diuresis? This carbonic anhydrase inhibitors, they indirectly affect this Na plus H plus pump. So they indirectly affect this Na plus H plus antipode because this enzyme is inhibited. So there will not be generation of this H plus ions. So no exchange of sodium takes place here. So this pump is indirectly affected. So sodium will not enter the cell. So what are the ions that are lost in urine in case of carbonic anhydrase inhibitors? So sodium ions are lost, bicarbonate ions are lost. So all these are lost in urine. Okay. So as you can see again, I'll repeat the mechanism. So carbonic anhydrase inhibition is there. So there will be indirect inhibition of this sodium H plus antipode, and sodium and bicarbonate will be lost in urine. So whenever sodium is lost, it carries water along with that. So it will lead to increased diuresis. Okay, this will lead to increased diuresis. Now let's move on to the side effects. So what are the side effects? What are the electrolyte imbalances that can happen when you give carbonic anhydrase inhibitor? So as I said, bicarbonate is lost in the urine, sodium is lost, okay, and also potassium is lost, okay. So potassium is also lost. So there will be hypokalemia. So whenever the urine is alkaline, so what happens? The calcium salts, they will be insoluble in this alkaline urine. So there is likely to form calcium phosphate stones. So there is a possibility of renal stones. So again, there will be metabolic acidosis will be there because loss of bicarbonate ions in the urine. So automatically there will be metabolic acidosis. Okay, and also hypokalemia and metabolic acidosis, they always go in pair. Okay, and and there will be retention of ammonium ions. So there will be hyperammonemia. So electrolyte disturbances. So when you see the mechanism, you can easily write what are the ions that are lost in urine. And these carbonic anhydrase inhibitors, they are sulfonamide derivatives. So majority of the diuretics, they are sulfonamide derivatives. So they are prone to cause hypersensitivity reactions. They can cause hypersensitivity reactions. So what are the uses of these diuretics? So these carbonic anhydrase inhibitors, they are poor diuretic. Why? Because whatever sodium that is lost in the proximal convoluted tubule can be reabsorbed in your loop of Henle. So loop of Henle is the site where maximum sodium reabsorption occurs. So the action of these diuretics is transient. Okay, transient. So they are poor diuretics. So what are the drugs? That includes acetazolamide, brinzolamide, dorzolamide. I think you could have come across while reading drugs for glaucoma in your autonomic nervous system. You will be familiar with these drugs. These drugs, they have a common suffix zolamide, right? So you all know they are given for the treatment of glaucoma as they reduce the aqueous humor secretion. Okay, these drugs are available as oral preparations, topical preparations, and even as intravenous preparations. So topically, they are given in treatment of open angle glaucoma. The drugs like brinzolamide, dorzolamide, and acetazolamide is given for the treatment of acute congestive glaucoma. Okay, glaucoma, there are two types: acute congestive glaucoma or angle closure glaucoma and open angle glaucoma. Okay, these carbonic anhydrase inhibitors, they are given for both types of glaucoma. Acetazolamide is given as oral drug for the treatment of angle closure glaucoma. So one main use, and another thing, they are also given for acute mountain sickness. So what happens in high altitude? Because of hypoxia, there will be, the patient will try to hyperventilate to the lungs has to get rid of that carbon dioxide. So the patient will be hyperventilating. Okay. So respiratory alkalosis will be there. So what your carbonic anhydrase inhibitors produce? They produce metabolic acidosis, which will balance your respiratory alkalosis. Okay. They are also used in treatment of obstructive sleep apnea. Okay. And they are also used in treatment of raised CSF pressure headache. So in case of idiopathic intracranial hypertension. Okay. And also in treatment of catamenial epilepsy by increasing the release of your inhibitory neurotransmitters, because in epilepsy you have already I think you would have already learned about that in your CNS. So in epilepsy, what are the drugs that are used? So either the drugs which are acting on the inhibitory neurotransmitters, it should stimulate that, or the excitatory neurotransmitters should be suppressed. So this carbonic anhydrase inhibitors, they act by increasing the release of inhibitory neurotransmitters, and thereby they are helpful in catamenial epilepsy. As they also produce, these drugs, they also produce hypokalemia. They can be used in familial hyperkalemic periodic paralysis. And one other interesting use, that is in cystinuria, cystine stones. Okay, so cystine stones, they are acidic, so they can be easily lost in alkaline urine. Okay, so alkaline urine favors the excretion of acidic drugs. Okay, so cystine stones. So main uses glaucoma, you should never forget. Okay, and also for acute mountain sickness. Okay. So now we move on to the next drug. So before that, so why I have given this picture is, so Kamal, he has led many roles. Okay, so which is unique among all the artists. So like this, your carbonic anhydrase inhibitors, they have multiple uses. Okay, so they have multiple uses among the diuretics. So next we will be moving on to loop diuretics. So how do these loop diuretics act? Now again we can go for the same teacup. Okay, same teacup. We can explain the mechanism with that. Assume this is your cell and this is your basolateral membrane. Okay, side you will be having this luminal membrane. Okay, luminal membrane. So what type of, what is the site of action? What is the cell where your loop diuretics will act? They will act on the thick ascending limb of loop of Henle. Thick ascending limb of loop of Henle. So what pump will be there in the basolateral side? There will be K plus Na plus ATPase pump will be there in the basolateral side. So what is the transporter that is seen on the luminal membrane? Here there will be sodium potassium 2 chloride transporter. Okay, sodium potassium 2 chloride transporter will be present on the luminal membrane of thick ascending limb of loop of Henle. Okay. So this sodium, potassium, 2 chloride all will be absorbed from the lumen inside the cell via this transporter. Okay, and there will be exchange of this sodium again with the potassium. Potassium will be entering again back into the cell, and one another transporter will be there which transports again sodium and chloride inside this basolateral membrane. So across this basolateral membrane, so this is absorbed. So more amount of sodium will be reabsorbed here. So to maintain this positive proper ionic balance, this potassium will enter inside this cell. Okay, so to maintain the balance, ionic balance, potassium will be entering more into the cell. So again, this here there will be paracellular space. Okay, so this is your paracellular space. Okay, so this potassium again drives more of calcium and magnesium ions to be reabsorbed across the paracellular space. Okay, so this is a thing which is happening in the loop of Henle. So loop of Henle is the site where maximum sodium will be reabsorbed. To compensate the ionic balance, potassium ions enter here. Again, this will again cause reabsorption of your calcium and magnesium ions via the paracellular space. This is how the mechanism operates here. Now what does your loop diuretics do? Loop diuretics directly inhibit this cotransporter, sodium potassium 2 chloride transporter. There we saw carbonic anhydrase inhibitor, they have an indirect action on this sodium H plus antipode. Here there will be direct inhibition of the sodium potassium 2 chloride cotransporter. So all these ions will be lost in the urine. Sodium, okay, so potassium, so everything will be lost. Okay, so also your calcium ions, magnesium ions, all will be lost in the urine. Okay, so there will be hyponatremia, hypokalemia, okay, hypocalcemia, hypomagnesemia seen with this loop diuretics. Okay, so again for recap, see, you can see loop diuretics inhibit this cotransporter. So more of these ions will be lost in the urine. Calcium ions and magnesium ions are also lost here. Okay. So why I have given Rajni's picture here? Because only one superstar, that is Rajni. Okay. Here superstar and diuretic, that is a diuretic with maximum efficacy is your loop diuretics. Why I have given the picture repeatedly is you should know what are the co-transporters or antipodes that are present in the that part of the concerned part of the nephron, so that you can remember the mechanism easily. So the transporters, they are more important, right? So what transporters in TAL, that is thick ascending limb, what are the transporters or antipodes which are present in the proximal pulmonary tubule? You should remember that. So see this image repeatedly so that you can easily remember the mechanism, and ultimately we can easily write the side effects too, because majority of the diuretics, they cause electrolyte loss. Okay. So what are the main uses of this loop diuretics, they are useful in treatment of acute pulmonary edema. Okay, acute pulmonary edema, in treatment of acute renal failure, chronic renal failure, and in case of hypertensive emergency. Okay, where the diastolic and systolic BP will be very high. Okay, hypertensive emergency, which we'll be seeing in the next class on antihypertensives. And also in treatment of barbiturate poisoning. So barbiturate is a barbituric acid, right? So there we need post-alkaline diuresis. Okay. So in here also we can use this loop diuretics. So this is the drug. When you go for IMCU, please have a look on this vial, right? So what are the drugs? We have furosemide, bumetanide, torsemide, and ethacrynic acid. Okay. So among this furosemide and torsemide are commonly used. Furosemide and torsemide are commonly used. Okay. All these drugs have potential to cause autotoxicity, whereas autotoxicity is maximum with ethacrynic acid. Ethacrynic acid can cause maximum autotoxicity. Okay. So, a patient may complain of fullness in the ears or ringing in the ears like symptoms. If any patient on these drugs, they complain these symptoms, think of autotoxicity. Okay. And also we should be very careful while giving along with other drugs that can produce autotoxicity, because there will be an enhanced risk like here aminoglycoside antibiotics like the gentamicin, which is commonly used in what's gentamicin, streptomycin, like these drugs. Okay, they can cause autotoxicity, and when you combine these loop diuretics along with aminoglycosides, the toxicity is increased. Okay. And again, the commonly used drugs like NSAIDs. NSAIDs is nothing but here non-steroidal anti-inflammatory drugs. Okay. So like aspirin, brufen, these drugs, they, what do they do is they interfere with the prostaglandin synthesis. Okay. And this drug and this loop diuretics should not be given. Okay. Because these loop diuretics, they enhance the prostaglandin synthesis, it can promote venodilatation. Okay. So apart from your this acting on the co-transporter, it has also other mechanisms that can help to act as a diuretic. But this NSAIDs, by blocking the prostaglandin synthesis, they blunt the effect of this loop diuretics. So I have said two important drug interactions with this group with the commonly used drugs. One is an antibiotic and one is an NSAID. Now let's move on to the other drug, that is your thiazide-like diuretics. Okay, thiazide-like diuretics. So how do these drugs act? Thiazide drugs. So we'll go on to the mechanism. So thiazide drugs, what do they do is, again we'll be drawing the teacup, right? Okay. So assume here is your basolateral membrane and here is your luminal membrane and this is your cell. So what type of cell? What type of cell it is? It is your distal convoluted tubule where your thiazides will act. So what type of pump should be here? Okay. So this is your Na plus K plus ATPase pump which is present on this basolateral membrane. Okay, basolateral membrane. And luminal membrane, what type of transporter is seen here? Here it is sodium chloride co-transporter. Okay, sodium chloride co-transporter which is present on the luminal membrane of this distal convoluted tubule. Okay, so again there will be another channel that will promote entry of calcium ions. And here there will be another exchanger. So that will cause exchange of sodium and that will cause exchange of sodium this side with calcium here. Okay. And another one channel, chloride channel will be there. So this chloride, whatever is absorbed via this sodium chloride transporter will be entering this chloride channel and it will be reabsorbed here. Okay. So reabsorbed here. So normally this happens here. So you can see this Na plus K plus ATP is pumped, which will promote sodium reabsorption, and potassium will be entering inside the cell. The sodium chloride co-transport will transport both sodium and chloride into the cell, and this chloride and sodium will be reabsorbed here. So this chloride will be entering via this chloride channel. So calcium ions again will exchange with sodium. Okay. So sodium enters the cell and calcium will be reabsorbed. So this is the thing which is present in the basolateral membrane of the distal convoluted tubule. Now, how your thiazide diuretics act? Okay. So this thiazide diuretics, they will block this, directly block this sodium chloride cotransporter. So they will directly block the sodium chloride co-transporter. Okay. So there will be loss of these ions in urine. Okay. Sodium chloride co-transporter is blocked. Okay. So now we can see the previous slide also. So let's see the side effects of the thiazides. So this thiazides is again notable to produce erectile dysfunction. Okay, erectile dysfunction in males. Okay, so again, the one side effect which is different from your loop diuretics is it can cause hypercalcemia, because calcium will be entering inside the cell for the exchange of sodium. Okay, so more of calcium will be reabsorbed, whereas your loops lose calcium, thiazides, it will cause hypercalcemia. And also it can cause hyperuricemia. Why this hyperuricemia is there? Because in the proximal convoluted tubule, thiazides will be secreted via a transporter called organic anion transporter. Okay, organic anion transporter. So this transporter again also, via this uric acid is also secreted. So this uric acid and thiazides compete with this transporter. Okay, so compete for getting secreted via this transporter. So what happens? Thiazide competes, so uric acid accumulates. So there will be hyperuricemia. And also there will be hyperglycemia because of hypokalemia. So what happens? There will be inhibition of insulin release. So automatically that will lead to hyperglycemia. So we must be careful in which patients? Diabetes patients. Okay. And also it can cause hyperlipidemia. Okay. So other electrolyte disturbances like your loops, it can also cause hypokalemia, metabolic alkalosis. Okay. So the thing which is different from your loop diuretics is your hypercalcemia and also erectile dysfunction. There we have seen a specific side effect, that is ototoxicity with loops, and erectile dysfunction with your thiazide diuretics. So in diabetes insipidus, there will be deficiency of your anti-diuretic hormone. So there are two types of diabetes insipidus. There is your central diabetes insipidus and nephrogenic diabetes insipidus. So in central diabetes insipidus, there will be deficiency of your ADH hormone, whereas in nephrogenic diabetes insipidus, what happens is the receptors will not respond to the antidiuretic hormone. So your thiazides are useful in treatment of nephrogenic diabetes insipidus. So I think you all have seen this movie. So what is this movie? It's not a movie. It's an episode, like it has 8 episodes, I think. Okay. So sweet corn coffee. So the three old ladies will be going for a trip. Okay. So sweet corn coffee. So since this diuretics can be, the mechanism can be remembered with the help of tea or coffee cups, I used the slide to show this. So this very old lady, for her, which diuretics is risky and which diuretics is beneficial? If you know the answer, check to the last slide. So She has risk if she takes loop diuretics because lose calcium because elderly are more prone for osteoporosis, right? And if she is on thiazide diuretics, again thiazides they cause hypercalcemia. So if she has hypertension, so hypertension we can give thiazides. Also, it will benefit for treating beneficial if the patient has got osteoporosis also. Thank you.